have you prepared your case?
Good afternoon, sir. Yes, sir.
So go ahead, present your case.
Good afternoon, sir. I am presenting case of 55-year-old male, resident of Sitapur and farmer by occupation. Patient came to hospital with chief complaint of cough since 4 years, breathlessness since 2 years, and fever since 7 days.
Okay.
History of present illness.
Okay.
Patient was apparently asymptomatic 4 years back when he develops cough on and off 4 years back. Insidious is onset, progressive in nature, and was associated with sputum. Earlier, sputum was white in color, mucoid in nature, but currently sputum is yellow in color and mucopurulent in nature. It is about 30 ml per day.
Suppose Dr. Syed,
yes, sir.
As you said, your patient had about 30 ml of mucopurulent sputum. What it suggests? How you found out that his sputum was mucopurulent? Patient may not have told you this. I have a mucopurulent sputum. So he must have told you something by which you have interpreted, yes, it was a mucopurulent.
So patient told that color of the sputum was changed. It is yellow in color.
So it was yellow in color. Okay. So yellow color, 30 ml
sir.
Yellow color. What other points in expectoration you did ask?
Sir, expectorations, so color.
Yes.
And nature, it is mucopurulent. Amount
nature you don't ask. Nature you interpret, right?
Yes, nature we interpret. Amount, yes. Sir.
Amount, yes, very good.
And smell.
Smell, yes.
Yes. And sir, hemopsis also, sir. Any blood
any associated. Anything in suppose somebody is expectorating.
Yes, sir.
You said apart from amount means quantity, then quality, then foul smell. Anything else you ask? Did you ask for any postural relationship?
Yes, sir. Sir, patient is having no postural variation, sir.
No postural variation. Suppose somebody tells you there is a postural variation. How it helps you?
It can be, sir, patient may having when patient is saying in that posture, he is having more sputum. It may be a case of bronchiectasis, sir.
No. Case of bronchiectasis. Well,
so the localization of the disease we can know, sir.
Yes, very good. It can from the history you may localize the disease, whether it's on the right side, on the left side, depending upon the postural relationship. Yes, so that is the help you're going to derive. Diagnosis wise, it is not that every patient of bronchiectasis may have postural relationship.
Yes, sir.
So it tells you the site of lesion. Yes. Where is the involvement? Yes. Okay, go ahead.
So patient is saying there is a diurnal variation. Patient saying more cough and with sputum is in morning. Okay. And seasonal variation is present more in winters.
Okay.
Patient also complains of shortness of breath, which is since 2 years. It is insidious in onset and progressive in nature. Earlier, patient was having MMRC grade 2. Now he is in MMRC grade 4.
Can you spell out what are the various grades of MMRC? Yes.
So in grade 0, so there are 5 grading. It starts from 0 to 4, sir. Sir, in grade 0, sir, patient complains of breathlessness when he do extraneous exercise.
Okay.
In grade 1, patient says when he walks in faster, when he walks fast, hurry up, or he walks in, he climbs the hill, he experiences breathlessness.
Okay.
In second, patient feels breathlessness when he walks with normal pace with his same age group.
Okay.
And in third, a patient walks 100 yards and he have to sit because he is breathless and then he walks. Okay. In grade 4, sir, patient complains of breathlessness when he undresses himself or he walks or he talks a lot. Okay. He talks a bit, he feels breathlessness. So there is no, patient is saying that there is aggravating factor that There is no aggravating factor and relied on taking rest and medication. There is seasonal variation in breathlessness, more in winter, and there is no postural variation. Patient is not complaining of orthopnea and PND.
Okay.
Patient is also complaining of fever since last 7 days, which is intermittent in nature, low grade, and no diurnal variation, and not associated with chills and rigors. Some negative history. Patient is not complaining of, there is no history of hemoptysis, orthopnea, PND, headache, burning maturation, chest pain, loss of appetite, loss of weight, nausea, vomiting. And there is no history of pedal edema also.
Why did you ask about the pedal edema? What it suggests to you?
Sir, it can suggest cor pulmonare, sir. Sir, right heart hypertrophy, sir.
What is car pulmonary?
So, cor pulmonare is a condition in which right ventricular involvement is there. It is called. Yes, sir.
This is not the complete definition of car pulmonary. What is the complete definition of car pulmonary?
So, it is a right ventricular failure due to lung disease, sir.
Now you are somehow on the track. Yes. Okay. So there is no evidence of pedal edema.
No, sir. The past history, there is no significant history. Patient is not complaining. No history of ATT intake. No history of tuberculosis, jaundice, hypertension, or diabetes mellitus, sir.
Okay.
Personal history. Patient is a smoker, chronic smoker. He used to have 20 BD per day for 30 years. Pack years is 30 and smoking index is 600.
Okay.
Family history. Patient total 8 members in his house, 2 sons, 2 granddaughters, daughter-in-law, 2 grandson and wife.
Okay.
Treatment history. Patient was on earlier patient was on irregular treatment of oral bronchodilator and no history of intake of inhaled bronchodilator.
Okay.
Patient also said that he used to have a white small tablets which was given by a local practitioner when he used to have breathlessness. So now I came to general examination.
So from history, what you can interpret? You can think of some differential diagnosis from the history point of view.
Yes, sir. So from history point of view, first diagnosis can be acute exacerbation of COPD.
Okay.
So second, sir, pneumonia. The most commonly, sir, in this scenario, is COVID-19.
Okay.
And sir, we can also thought of pulmonary tuberculosis.
Okay.
And also one more lung cancer.
What was the age of patient?
Sir, 55 years.
55 years. Okay. So these are 3-4 possibilities you think after taking the history.
Yes, sir. Sir.
Go ahead for physical examination.
So generally, the patient is well oriented to time, place, and person, and comfortably sitting on chair. Sir. So in positive finding, sir, in general examination, patient is tachypnic. So respiratory rate is increased. So patient is using his accessory muscles. So in upper respiratory.
Do you know what are the accessory muscles of respiration?
Sir, Alan-Izai, sternocleidomastoid, sir, platysimus, and scalene.
Okay. Go ahead.
Sir, in upper respiratory tract, sir, patient is having poor dental hygiene, sir.
General examination is complete.
Yes, sir. So you said positive finding, sir.
No, positive, but when I say positive finding, you have to tell important negative finding also.
Okay, sir.
Rule says like this.
Yes, sir.
So what are the important negative finding in this particular patient you wanted to tell me?
So there is no pallor.
No pallor.
No cyanosis.
No, very good. No cyanosis.
So no lymph node enlargement.
No lymph node enlargement.
So
yes.
no clubbing.
No club.
Yes, sir.
And
so no JVP raised and no edema, sir.
No edema. Good.
Yes.
Okay. Go for the systemic examination.
Yes, sir. Sir, in lower respiratory tract, Sir, on inspection, sir, barrel-shaped chest is seen, sir.
On inspection. So what is the first thing in inspection you should tell?
Sir, in inspection, sir, we see upper respiratory tract and lower respiratory tract. In upper respiratory tract, sir, I have told, sir.
Now you are on the lower respiratory.
Yes, sir.
So you want to tell something in the upper respiratory tract?
No, sir.
Think positive.
Sir, poor dental hygiene, sir. Nicotine stains, sir.
Okay. There is no DNS.
No, sir. No DNS, no polyps, sir. No deviated. Yes, sir.
Then in the respiratory system, you said inspection.
Yes, sir.
You started with barrel-shaped chest.
Yes, sir.
You know, professor usually talks like this. As a student, what should be the first thing in the inspection?
Sir, shape of the chest, sir. Yes.
When you inspect, even before shape of the chest, what do you inspect? First thing.
Sir, movement of the chest.
Movement of the chest.
Yes.
Why movement of the chest? Can you explain why I said the movement of the chest? When I examine the chest, the first thing I inspect is the movement. Why? Question is this: why?
Sir, if there is a localized disease, the movement of that hemisphere can decrease.
So what we try to understand, shape of the chest can move both the way. Suppose there is a bulging in the chest, or there could be retraction in the chest. Both way it is possible. But in the movement, only one way is possible. And the dictum you remember, dictum you remember, that side which is moving less is the disease side. I have told you in your many times classes, even I have got YouTube for physical examination, you must have seen that. There I always tell the first thing is to look for movement of the chest, because the side which is moving less is the disease side.
Disease side.
And then you may go on the shape of the chest,
Yes,
because then shape of the chest can move in both the way. There could be depression, there could be bulging. So if you know the movements, side which is moving less, that's the disease side, then it is much better to correlate the shape of the chest. That is why it is always said that first thing you see during the inspection is the which side is moving less. Because every time our question in mind always remains, which side is disease if it is unilateral disease. So probably that is the one finding which makes you much wiser. Okay, so there's any finding in the movement, or whole of the chest is moving?
Bilateral equal, sir.
Bilateral equal. Good.
So shape of the chest is bilateral symmetrical, but it is barrel-shaped chest, sir.
It is barrel shape. What is barrel shaped chest?
So barrel-shaped chest is, sir, AP diameter and transfer diameters are almost equal, sir.
Okay.
So trachea is centrally placed. There is no drooping of shoulders.
Yes.
So spine is central. So spinal scapular distance is bilaterally equal.
Yes.
So apex impulse is visible, sir.
Okay.
Hoover's sign is positive, sir. So it is a
when apex beat is visible, you should, although measurement you cannot do during inspection,
yes, sir.
But you can say roughly yes in a precardium.
Yes.
Suppose some pulsation is visible on the right side, then probably you have to say that there is some visible pulsation
yes,
on the left side, which area, precardium,
yes.
and which possibly maybe apex beat. Yes, go ahead.
So Hoover's sign is positive. So there is no dilation.
What is Hoover's sign?
So Hoover's sign is a proximal indrawing of chest, sir. So there is no dilated veins or scar. So patient is using accessory muscles on inspection, sir. Sir, now we come to palpation, sir. So finding of inspection are further confirmed by palpation, sir.
Okay.
Sir, temperature is raised. Sir, there is no tenderness. Movement of chest is bilateral. Trachea is centrally placed. Spinoscapular distance is bilateral.
Movement of chest is bilateral symmetrical.
Yes, sir.
Okay.
Sir, hemithorax, both are bilaterally symmetrical.
Okay.
Equal. Chest expansion is 2 centimeters, sir.
Hmm.
Sir, and AP and transverse diameter is 0.96, sir. So apex
The
beat,
ratio of AP and transverse is 0.9.
yes. So apex beat is palpable. So it is 1.2 centimeter medial to mid clavicular line, sir.
Can you define what is apex beat?
So it is a lowest most and outermost cardiac impulse, sir.
So it is a finding, basically it is a finding of palpation.
Yes, sir.
And it is the lowermost and outermost point of cardiac impulse which is best felt.
Yes,
That is why it is mainly finding of palpation.
Palpation, sir.
Okay.
So percussion, sir.
So apex beat is not shifted. Trachea is also not shifted.
No, sir.
Okay.
Sir, percussion, sir. Sir, in percussion, sir, chronic isthmus on right side is 5 centimeter, and it is on left side is 5.5 centimeters, sir.
Okay.
Sir, in clavicular percussion, sir, it is normal, sir. Infraclavicular resonant, sir. In mammary, sir, resonant. Axillary, resonant, sir. Infraaxillary, resonant. Suprascapular, resonant. Intrascapular, resonant. And infrascapular is also resonant. So liver dullness is at 6th.
So all the areas of chest are resonant.
Yes, sir.
You want to say this is a normal resonance?
So hyperresonance, sir.
So there should be difference between the normal resonance and hyper. So it is hyperresonant.
Yes, sir.
This is more than normal.
Yes, sir.
Okay.
So liver dullness is on 6th intercostal space, sir, right side. So tidal percussion is normal and Prof space is tympanic, sir.
Trough space is tympanic.
Yes, sir.
Trough space is there.
Yes, sir.
Okay. Can you define the boundaries of the trough space?
Yes, sir. So in mid clavicle, sir, we take 2 lines.
What are the boundaries of trough space? If you don't know, say I don't know.
Sir, on left side, sir. Sir,
Of
on
course,
right.
it is on left side.
Yes, sir.
Trough space is on left side unless there is a situs inversus.
Sir, left lobe of liver, sir. On the right side.
Left lobe of liver, okay.
And sir, and anterior on left side, it is anterior border of spleen, sir.
Anterior border of the spleen. कैसे पता लगाओगे भाई palpation में?
Sir,
what is the upper boundary and what is the lower boundary? What I am interested more. When you percuss about the trough space,
yes, sir.
so you wanted to know upper, what is the upper line and what is the lower? So what is the upper and what is lower? Tell me this. Of course, medially it will be bounded by left lobe of liver. So what is the upper? From where it starts? I am keen to know from you.
Sir, resonance of left lung, sir. Upper resonance of left lung.
Actually, the trough state starts from the lower border of the lung resonance, where lung resonance is replaced with hyperresonant or tympanic node. That is the actual area. And what is the lower boundary?
So costal margin, sir.
Yes, subcostal margin. So it is not below the costal margin. You will all find a tympanic because of the fundal gas shadow. But it is also because of the fundal gas shadow, but part of it comes into the chest. And that area is known as trough space.
Yes, sir.
So lower lung resonance is the upper boundary and subcostal margin is the lower margin. So it is hardly a space where there is a tympanic resonance. Okay. And it is because of the fundal gas shadow.
Yes, sir. So next finding is on auscultation, sir. Sir, on auscultation, sir, there is bilateral reduced air entry.
Yes.
So bilateral harsh vesicular breath sound. Sir, on added sound, there are rhonchi, sir. And sir, vocal resonance is normal, sir.
You want to say that there is a reduced breath sound and there is a harsh vesicular breath sound. Both you are telling. Okay. What is harsh vesicular breath sound, by the way?
So harsh vesicular breath sound is, say expiration is prolonged, then inspiration, sir.
So it is a vesicular breath sound with prolonged expiration.
Yes,
prolonged expiration.
Expiration, sir.
So there is a harsh vesicular breathing all over.
Yes, sir.
And they are Rankai alveoli. What about Krebs?
So no Krebs, sir.
No Krebs. You are saying acute exacerbation. You are saying 30 ml of expectoration. Okay, go ahead. I will check.
So here I complete my history with examination, sir.
No, examination is complete.
Yes, sir.
No, it is not complete.
Sir, or, yes, sir. Other systemic examination, sir.
So when
So
you
are within normal, sir.
the other systems are normal. Which system you are trying to see most in this particular
The
case?
cardiac, sir. Cardiology.
One is cardiac, another
Sir.
Cardiac. What you'd like to find out in cardiac?
Sir, we'll find, sir, in some patients, sir, in like core pulmonary, sir, P2 in second heart sound, sir, P2 is loud, sir.
You want to see is there a cardiomegaly, borders will percuss.
Yes, sir.
You will listen the pulmonary area for loud P2. That may suggest pulmonary hypertension.
And so superficial cardiac dullness also, sir.
And superficial cardiac dullness, it may be masked.
Yes, sir.
Okay. And any other system? So cardiac is one. In this particular scenario, when you are suspecting, when first diagnosis you made like from history is a COPD. So
sir, nervous system, sir, for CO2 retention, sir.
For CO2 retention, very good. What else? Any other system which may be important in this patient?
Sir, abdominal, sir.
Abdomen, very good. For what? Abdomen for what?
Sir, tender hepatomegaly, sir.
So you wanted to see the signs of congestive heart failure.
Yes, sir.
In abdomen. Okay. So other systems were within normal limit.
Yes, sir.
Now what is your diagnosis?
Sir, acute exacerbation of COPD, sir.
Acute exacerbation of COPD. So basic diagnosis is acute COPD, and he presented with acute exacerbation this time. Any other diagnosis you want to put in your differential diagnosis?
Sir, pneumonia, sir. COVID-19
pneumonia.
Sir, as patient is complaining of fever since 7 days and cough also.
No, after you examine the patient, there is no craft, there is no bronchial breathing.
No, sir, we cannot say it.
There is a harsh vesicular breathing. How you are going to put consolidation as one of the? There could be bronchiectasis. The history is very long, 5 years. Cough with expectoration.
Yes, sir, it can be, sir. So loud thinking, sir, we can include sir bronchiectasis.
No, I am not talking now after history. Loud thinking is done after history.
Yes, sir.
After physical examination, no loud thinking. Now your diagnosis should be based upon the clinical findings. So do you get any finding which can compel you to think, yes, there could be a bronchiectasis?
Sir, we are not having, we didn't hear, sir, Krebs, sir. There is no clubbing. And patient is also saying that he's only having 30 ml of sputum per day, sir.
So why you are thinking
yes,
about
sir,
bronchiectasis?
Not, sir, think.
You say from the history and from physical examination.
Yes.
You cannot suspect bronchiectasis. In CT you may get bronchiectasis, but you cannot
yes, sir.
suspect bronchiectasis. So your diagnosis is COPD with acute exacerbation.
Yes, sir.
Okay. So how will you proceed this case to investigate?
So first, we will get done, sir, X-ray chest, sir.
Okay.
Yes, sir. And we will send sputum. So we will have sputum culture, sir.
Sputum culture for what?
Sir, any specific growth, sir?
Any growth of mycobacteria,
yes,
of the bacteria, pathogenic.
Yes, sir. Yes, sir.
Have you read any guideline which talks about in lower respiratory tract infection routine cultures to decide about the bacteria? I'm talking of he's not in ICU, he's not in SDU, he simply has come to you in your wards. In this scenario, really you want, rather in other words, if I ask you a question, what is how the sputum culture helps you.
No, sir. We will not go for sputum culture, sir.
There it can be important, but here in this case, for a simple exacerbation, community acquired exacerbations, do you know what are the common bacteria which infect lower respiratory tract?
Sir, Klebsiella, sir, H. influenza.
Klebsiella is not common. What is the two commonest organisms which infect at the community level?
Sir, Streptococcus, sir.
Streptococcus or
Sir, H. influenza, sir.
H. influenza, yes, good. And pneumococcus, Streptococcus pneumoniae, right?
Streptococcus pneumoniae.
These are, and you know them, how they are sensitive, how they are resistant. That's why. So anyhow, you did your X-ray और क्या कराओगे? चलो culture भी करा दिया, मान गए, but the result you have to take with pinch of salt, because whatever sputum comes, it comes through the oral cavity, and oral cavity has a full of bacteria. So it is very difficult.
So we will go for complete blood count, sir.
Okay, blood counts. और क्या कराओगे?
Sir, after resolution of exacerbation, we will go for pulmonary function test, sir.
So you will go for pulmonary function test is a big issue. What in pulmonary function test is like? Pulmonary function test क्या कराओगे? Spirometry कराओगे?
Yes, sir.
Diffusion भी कराओगे?
No, sir.
क्यों?
Diffusion, yes, sir.
Diffusion क्यों नहीं कराओगे?
नहीं sir, करवाएंगे sir.
So you may again that spirometry and diffusion.
Yes, sir.
Okay. और कोई investigation?
Sir, 6-minute walk test, sir.
Okay, 6-minute walk test, good.
CT thorax, sir.
CT thorax. Why CT thorax?
Sir, pattern of emphysema, sir. To see the pattern of emphysema.
To see the type of emphysema, right? Pattern of emphysema. Okay.
Yes, sir. And extent of its involvement, sir.
Extent of may I share you one of the X-rays?
Yes, sir. Please, sir.
I'll just look if I have X-ray is visible to you.
Yes, sir.
Ahmad?
Yes, sir.
So suppose this is X-ray. Read it.
Sir, this is a chest X-ray.
Yes. Go ahead.
It is a PA view chest X-ray.
Yes.
Sir, well exposed.
Yes.
Sir, no rotation seen.
Okay.
So soft tissue, normal, sir.
Okay.
Trachea centrally placed.
Okay.
Bony cage normal.
Okay.
Sir, no mediastinal widening seen.
Okay.
Sir, on right side, level of diaphragm is on 7th rib. On left side, level of diaphragm is 6.5 on 6.5. Parenchyma, sir. Parenchyma is normal with hyperlucent in lower bilateral lower lobe, sir.
Hyperlucent shadows. Yes.
Yes.
What about heart?
So heart is normal, sir. No cardiomegaly, sir.
No cardiomegaly. Okay. What is usually heart in such type of X-rays? Pendular. Have you heard name of pendular heart?
Yes, sir.
Long and thin heart. So what X-ray suggests to you?
It's a COPD, sir.
X-ray suggests to you there is evidence of overinflation.
Yes, overinflation.
And some increased lucency in the lung field, so appears consistent with the COPD.
Yes, sir.
Right?
Yes, sir.
Suppose so this was the X-ray.
Yes, sir.
How you will proceed to treat this case?
Sir, we will grouping will be done according to gold guideline 2021, sir. So patient is coming is in group B, sir.
Patient is in?
Sir, group B, sir.
Okay.
Sir, in
group B, how you find out? Suppose I provide you the PFT. So how you find out group B?
Sir, PFT values are not included in grouping, sir.
No, PFT values included in the diagnosis.
Yes, sir.
So what? Suppose I provide you the spirometry. What you would like to see?
FEV1 by FVC, sir.
First thing you will see ratio of FEV1 and FVC.
Yes, sir.
Which one? Pre-bronchodilator or post-bronchodilator?
Post-bronchodilator, sir.
Post-bronchodilator. Okay. And then next thing you'll see?
FEV1, sir.
FEV. Post bronchodilator FEV1.
Yes. Yes, sir.
Okay. So to decide whether there is airway obstruction and what is the severity of airway obstruction.
Yes, sir.
And then subsequently you group them into A, B, C, D.
Yes, sir.
So which group your patient belong to?
Sir, group B, sir.
Group B. Okay.
Yes, sir. Sir, as patient MMRC grading is 4, sir, and CAT scoring is more than 10, sir.
Group B or group D? What do you want to say?
B, sir. B.
B. Okay. B. And
So
no,
there is no hospital administration, sir.
there is no hospital admission. Though exacerbation history you find less than
Yes, sir.
less than 2. Huh?
Yes, sir.
Okay. So how will you manage this case?
Sir, in group B, sir, we will give any long-acting beta agonist or a long-acting muscarinic agent, sir.
As you said, there is a lot of bronchi.
Yes, sir.
In your case. So what is the role of steroids, inhaled steroids in this patient?
So for short course steroid, sir, oral steroid we can give, sir.
No, short course oral steroids for acute exacerbation. That's okay. Now suppose you put on her on combination of LABA-LAMA, as you said, and his response was not satisfactory.
So we will give sputum eosinophil count, sir. If eosinophil count is more than 300, so we will add, sir, inhaled corticosteroids, sir.
And can you think of, so while in treatment of COPD, what are types of surgery you may think of?
Sir,
I'm not asking this particular patient.
Yes, sir.
In COPD, what type of surgeries you know?
Sir, bullectomy, sir. Sir, lung volume reduction surgery, which is, and bronchoscopic procedures, sir. We can put valve, coils, or stents, sir.
Okay.
And thermal ablation, sir. Thermal vapor ablation, sir.
Anything else?
And lung transplantation, sir.
Lung transplant. Do you know what are the indications of lung transplantation in COPD?
Sir, age more than 65, board index greater than 7. FEV1, sir, more than 35.
More than 30?
No, sir, more than 50, sir. FEV1, sir.
More than 50? Lung transplant तो तुम्हारे हर मरीज को lung transplant हो जाएगा. Please read. There are definite indications for lung transplantation. It appears you have no idea. Okay, Dr. Syed. And suppose patient asks you one question.
Yes, sir.
What would be my prognosis? How I'll fare rest of my life? So what you are going to tell?
Sir, we will explain the patient about its disease, and we'll tell him that for life he will have some sort of difficulties in breathing, and for life he will have a little bit breathlessness, and he have to be on medication, sir. Okay. On regular medication, and he have
anything else you tell in the treatment?
Sir, we have to quit smoking, sir. We have to ask him to quit smoking.
That would have been the first thing.
Yes, sir.
So you have to advise him to quit smoking.
Yes.
Okay. Sir. What else you'll advise apart from antibiotic those drugs?
Sir,
what other things?
Sir, adherence to inhaler, sir. Proper techniques of taking inhaler. Sir.
What else?
Sir, rehabilitation, sir.
Pulmonary rehabilitation is a very important issue, right?
Yes, sir.
Anything else you would like to advise your patient to reduce the exacerbations?
So vaccination. Sir.
Very good. Vaccine. So these are the basic. Okay, Dr. Syed. Thank you very much.
Thank you, sir.